equity. This keynote will be given by Dr. Edna Tallam. I hope she's already online or physically. Please confirm. Daktari, confirm if you...
I don't know if you can hear me.
Excellent, we can hear you. So before Dr. to speak to us this morning, Dr. Tallam is a nurse leader. She's an educator and a policy in nursing education. He serves as a senior lecturer and head of community health at Amref International University and is a member of the Global Nursing Advisory Council. As the former registrar and CEO of the Nursing Council of Kenya, he spearheaded landmark regulatory reforms that earned the ICS Champions of Governance Award. Her leadership strengthened professional standards, accreditation systems, and institutional governance across Kenya's nursing and midwifery sector. Dr. Tallam has played a pivotal role in primary healthcare, health workforce, and system strengthening, focusing on capacity development, policy alignment, and implementation of sustainable community health strategies. He continues to shape global nursing and health workforce policy through her leadership with the International Council of Nurses, including contributions to the Global Nursing Leadership Institute. She also serves as a joint secretary to the Kenya's presidential workforce on addressing human resources for health, advancing national reforms in health workforce planning, governance, and service delivery. With the so many pillars you stand for, Doc, please take it away. Welcome.
Absolutely, absolutely. Thank you so much, Chair, and good morning, good evening, colleagues, depending on where you are joining. It's really my honor and a privilege for me to talk to you from various aspects at our International Nutrition and Dietetics Scientific Conference. I also received kind regards from Professor Tamari Rotich for Amref International University, who is not able to also join you, and receive greetings from the entire Amref. All right, so today we'll have a conversation, and our conversation is us as nutrition and dietitian, how do we nourish our health systems? And this being a foundation of the health equity. So overall, nutrition and dietitian, whatever we eat, whatever we consume in our bodies, and your profession is what we envision as a central building block for strong health systems. It's really not a complementary services, and I've worked in the clinicals and we've interacted. As much as we have patients in our wards, in our communities, we have clients, whatever we provide to them, the nutrition itself is not a complementary, but it is a service which is strategic, which is needed for us to be able to achieve an extremely robust and equitable and sustainable health systems. And today, the evening dinners, we were even taking, I'm in a different time zone, and we had this conversation, and I was telling colleagues that I need to rush to prepare for today's talk. And we were reflecting on what we are eating, we are reflecting on our nutrition, and also what does life hold if we are not being able to take care of that. So we are not a complementary service. It is a service that it is needed within our health systems. So you cannot build a strong health systems on the foundation of malnutrition. You can't. When we have our children, when our children grows up, we cannot be able to sustain our nation. We cannot sustain our nations when we have issues of malnutrition. So on its burden, and it exists in various forms when we talk about one aspect of the nutrition, which is a malnutrition, which has been spoken by many speakers before me. The undernutrition, the micronutrient deficiencies, the issues of overweight, the issues of obesity, and these all of them really undermines our health system's performance. Within our country, within our Afro region, we used to have communicable diseases. Right now, the NCDs, non-communicable diseases, are rising to an extent that it is straining our health systems. We didn't have a lot of hypertension, we didn't have diabetes, we didn't have all these NCDs, things are coming. But it's just because the underlying factor is the issues of the nutrition. How do we be able to balance? And that needs to be thought through, because we do not want to increase the disease burden and its associated health costs. So when we address the malnutrition, for example, it is really essential for us to also address the universal health coverage and going ahead to improve the population's health outcomes. So hang on, let's just check about the crisis that we face when we do not take the nutrition or the profession of the nutrition and dietitians as a profession that it needs to build our health systems. It has a triple burden which undermine our health systems. We cannot build our health systems when we know that there's a crisis that we face. And this is, for example, the undernutrition. When we have over 149 million of our children being stunted globally, it has the wasted. And what does that mean? It means that there is also micronutrients deficiencies, and this is an hidden hunger. It's an hunger that we don't see, but it's an hidden hunger. And the overweight, again, we see over a billion adults who are overweight, and these NCDs contribute to over 71% of the global deaths, and I'll be able to provide the reference. So our health systems may collapse if we don't work on the triple burden, from the undernutrition to the micronutrient deficiencies to the overweight and the obesity. And this leads us to longer stays in hospitals, and it burdens the health systems. We are able to see at the moment, especially with the non-communicable diseases, something over 20 years, it was not what we would have considered as what was so heavy that it burdens the little resources we have. So it's not, nutrition is not a problem. It is an health systems failure. So we need to start addressing, we need to start thinking through it, we need to start building on all the work that we've been doing as a professions, and ensure that we support the systems, we support our families, we support the primary health care that we really want to be able to serve them. Then what will look like as a strategic solution? Just reflect on your community, on where you serve, on where we have our professionals being there. I've worked with most of you, and the nutritionists and dietitians are the clinical experts. It is the medical nutrition therapy for the non-communicable diseases. My mother is diabetic, and every time we go there, we talk about the nutrition. We talk about the portions of the food that she needs to be able to serve. We talk about the diet. What is it that she needs to increase? What is it that she does not need to increase? But she's lucky because we are there. We are there in the family to be able to guide. How many people don't have people to guide them in the basic issues of the diabetes, that you need to be able to control your diet? It's all about diet. The medicines will be able to control it, but it's all about the diet. Being clinical experts, you are early detections of diet-related conditions and enhance the patient's recovery. Every time we have patients in our wards, we have our plants in our community. Medicines cannot be taken when you have underlying issues of the nutrition, and you need a nutritionist and a dietitian to come and carry them along in the journey of recovery. You are the public health champions. The population's level prevention, our whole population depends on you. We can't call a public health officer to talk when we don't have a nutrition, who have access, what is available, the environmental challenges, the food which is available, the locally made food, the alternatives. You are able to provide the community nutrition educations, no one can do that. You are the trusted one in the community. And food systems advocacy. You know which foods are there, and you are able to guide because you do understand what a starch is, and what a protein is, and what a carbohydrate is. And you understand what is fat, what are the other supplements we need, what are needed within the all cohort of life, from pregnant woman to the early child neonates and the child, to the child and the teenager, adolescents, to the young adults, to the adults, and to the elderly. The entire life cohorts, you do understand what they need. So you are able to do the food systems advocacy. Again, the policy leaders, evidence-based guidelines, and I've seen your CEO most of the time even advocating on additional employment of nutritionists and what does that mean, what is the effect and the impact within our health systems. So you provide the health systems reforms and you provide the universal health coverage integration within the community. So where does the integration works? The integration starts all the way from the primary health care. When there's a reduction in the child stunting, when we advocate for exclusive breastfeeding and there's the increase of the women providing the feeding to our children, we are able to strengthen community resilience because our children will be born, they will be able to have extremely good immunity, they will be able to grow, and they will be able to serve. So the community will be that resilient and will be able to sustain the gains that we've done, including immunizations as we walk along with life. When we provide the non-communicable disease management, and this is the integration on nutrition and dietitians working within the health systems and strengthening the health systems, there'll be fewer diabetes-related admissions. I love using the diabetes when we talk about the NCD because this is something that I have managed. This is something that it is within our family. This is what we encounter most of the time on our day-to-day. And I'm not saying other NCDs are not quite important, but they are. But for our conversations, I'm focusing on having fewer diabetes-related admissions. What does that mean? It means that we are able to manage our patients, our clients at home, where they don't have to come for admitted. They'll only come to be able to review, to do their tests, to just ensure that they liaise with the teachers and nutritionists to be able to guide them, to counsel them and advocate them for the good practices. Then there is reduction in healthcare costs for patients because we don't have any unnecessary admissions. And what does that mean? It management. The patients are able to self-manage themselves. They will be able to manage the condition. They'll be able to know the food portions that they need to be able to eat, what time are they able to eat, and what is required for them, even at the moment that they will be able to have the usual feelings of hypo and hyper, and that is the moment that they will be able to make these changes and alternatives. So that is where we integrate. In the maternal and child health, we will have increase in adequate gestational weight because we are taking care of the woman during pregnancy and during the birthing processes. And what does that mean? It means that we will be able to have a child or a baby, a neonate that is born with the adequate weight, and we will not be able to have issues of the underweight. We will also ensure that the woman is able to just have a good and successful birthing processes and the entire pregnancy period because there's reduction in anemia and also there's reduction in low birth weight. So we are able to be able to save. So these are the gains that we'll be able to see as part of the impact of good nutrition, good taking care of the family, the community, the women, the children, and the entire life cycle of life, from a neonate to being an adult. So our strategic investment in nutrition will be able to work. When we are able to provide this integration, we are able to just fit within our dose with working within the primary health care, and we'll be able to resolve the things that we are able to figure out. So we need to integrate it into our primary health care. And this is in the front of checking on the maternal and child health, the chronic diseases management, including the NCDs, and health education and promotion. And why is this health education and promotion is important? It's just important because we are human. Know that we don't know. It's because we need to be able to listen to the experts more often. We need to be able to provide that integrations and that conversation, peer conversation with our community on what is good as practices, what are the good practices areas, what are the food being available, and how do we ensure that we have food that we are able to be able to take care of our bodies, we are able to provide all the nutrients, and where we need a supplement, we are able to be able to get them within the reasonable resources that we have. And it's varied, and we are seeing a lot of NCDs coming in even among the people who are rich and those who are wealthy, because initially the malnutrition and all those conditions were associated with poverty, low socioeconomic status, which was associated also with educational levels, and a lot of you have done the presentation this morning and the previous days on trying to be able to get the data and the research that we've been able to do being a scientific conference. But we still don't have good health promotion activities. So we need to be able to embed the nutrition into the health education, health promotions. We need to include them into the health talk for school health and those, because that is where we will be able to meet the primary health care. When we talk about the women and the children are those who are within the community. Men, of course, included when we talk about the chronic diseases here within our primary health care. And this is able to lead to better and efficient healthcare systems because we embedded the nutrition within our healthcare systems. So why then that health and nutritional professions? Because you provide the preventive care, you do the screening, you do the education, you do the early intervention. And when I said early, it is as early as 0 days. It is as early as immediately when the baby is born. And you need nutrition, and you need the breastfeeding, you need the exclusive breastfeeding. So that early intervention is none other than dietitian and nutrition professionals who offer that. We need to provide the therapeutic support, the diet, tailoring the diet in clinical care. When we admit the patient, the first thing after we give them a bed, we give you the painkiller, is the nutrition and dietitian at the bedside to be able to work into a plan of the food, to be able to just also ensure what does this particular client need. In health promotion, you matter a lot because when you go to the community-based outreach and advocacy and the entire clinicians and the health clinic, the medical team will just come and they'll be able to provide the care, the management, and provide the medication. But that medication does not work when you don't have a dietitian and nutrition to be able to work in. They will vomit. So once you vomited, so what then? Once the children will not be able to eat all the food, it is there that we work step by step to be able to provide the diet and the nutrition which is required. So we provide the health promotion and community-based outreach and advocacy. We advocate for them. Why do we matter? We matter because of cost reduction, improved recovery, fewer hospital admissions, because we have been able to take care of our community. So we do matter. So what? We need to change the paradigm to escalate. Our old paradigm was nutrition as an optional service. We've seen hospitals and healthcare systems, and even within the hospitals that I did have, we were seeing the numbers, the distributions in our healthcare systems, in our hospitals. There are few numbers. Most of the time when they advertise, they will always advertise for nurses, medical doctors, clinical doctors, and a few nutrition and dietitians. And that is an old paradigm. There was vertical and isolated programs that needs to be able to be integrated together as a multi-sectoral, multidisciplinary approach. the nutrition was reactive malnutrition treatment only, and it was underfunded, it was underprioritized, and it is a misconception, a big misconception that anyone can give nutrition advice. It's not anyone, because there are nutrition and dietitians who have been trained for long, who are professionals, who are experts in that field. They've gone and filled the field. They do understand when we talk about the nutrients. They'll speak with authority because they are the subject matter in that field, and no one can be replaced. So no, it's not anyone who can give the nutrition advice. No, that is an old paradigm. How do we then shift to a new paradigm? And this is where nutrition is embedded in the systems design. When we design our systems, the nutrition has to be part of that. Remember, colleagues, when HIV came in, it went into a national policy because it got the attention it required. Nutrition needs to get the attention it requires. Especially with the rising STDs, it's not an option. We need to integrate across all levels of care, within the preventive and the treatment continuum, adequately financing and ensuring it is part of the universal health care packages. And the nutrition and dietitians need to lead the way. When we require that expertise, it has to be professional-led and to be driven by the evidence. And I'm glad that this conversation the last 2 days and today and the subsequent days, a lot of conversations have been done on evidence-based, that there's evidence to be able to back this. And I think within the nutrition and dietitian field, it is very easy because we are able to quickly see the outcome and the impact of the bigger population. So my plea today, as we all have this conversation, we need to change from the old paradigm and shift to the new paradigm. Because this is the Kenya we want, and this is the Africa we want. So systems strengthening through nutrition is to have human resources development in nutrition. The nutrition is available in studies, reduced government funding needs to be brought back into the systems. Policy and governance reform to institutionalize the nutrition goals. That nutrition is not about serving food and the people that they will be able to bring food to the patient. It is the entire process of ensuring that the nutrients are available, the patients are able to take, the community, the people, just the way sometimes as mothers and as women in our homes, we need to be able to provide a meal. But that meal has a science behind it. It has to be a balanced diet. It has to be a meal that the family will be able to be happy with and to provide those nutrients on what they are needed. Against strategic finances, I know we are facing tough time in our country, in our economy, and we have a small envelope that we need to be able to ensure that we plan accordingly, we strategically advocate, say that the funding and the financing is taken to the program that is defined and it is aligned to the nutrition and the needs of our community. So we need to strengthen our systems to meet our nutritional goals. And having said that, we need to fix proper nutrition as a support to nutrition as part of our system care. We need to embed nutrition in health systems design, as I mentioned, budgeting and financing, governance and accountability, and this is a key to building sustainable, reprospective healthcare systems. It is part of our systems pillar that we need to be able to strengthen. So a world where health systems nourish is what we envision when we bring the nutrition as part of the bigger health systems pillar, that we are able to see that this is the pillar that we need to be able to do that. And there's a lot of it, even in sustainable development, our SDG, no hunger is part of our SDG that we have it, and even within our vision 2030, it is within our social pillar that we just need to be able to bring up a population of good growth. So every child born should be well nourished and they should be able to grow to their full potential. Every adult should be able to prevent and manage diseases through good nutrition and habits. Every health system should integrate nutrition seamlessly and it should be led by professionals. And when I said led by professionals, are led by professionals who've been certified by the Kenya National Dietitian Institute and its equivalent because we work in a global village. Every country should be able to build people-centered sustainable systems. And if not nutrition, so what? If not now, when? And if it's not us, who will be able to do that? So we have the knowledge, we have the evidence, colleagues, and we are the people. We have the people. What we need is the will for us to act. Let us come out from our comfort zones. Let us act. Let us provide the care that we have to the population that they so dearly deserve to be supported. Allow me, Chair and colleagues, to quickly take you through what is it that then the Amref International University is supposed to do that. Part of the vision of the Amref is to bridge the gap in accessing education and marginalized communities in Africa. We are an Africa university, and it is a university of applied sciences, and our focus majorly is in primary healthcare focus. And that is why the nutrition and dietitians matter so much to us, because we are founded and we are connected within the bigger NGO Amref as Africa. Again, Amref International University provides challenges that we have to respond as a university in regards of the health, in regards of the education, and also in regards to the research that we have continued to provide. So we respond to the African health challenges. And this is the challenges of the high disease burden, challenges of rapid increasing population, inequitable access, over 400 million people that they don't have access to the care. Is it a fact? Less than 1% of the global health expenditure is within the health. We want to respond to the challenges of highest mortality rates, which accounts for half of the world deaths of children below 5 years, and only 3% of the world health workers. So it is a risk to the global health security, and we also want to respond and to address the disease risk in preconditioning driver and outcome of sustainable development. I mentioned the SDG 2 of no hunger. That's why we are having this conversation today. The gender inequality, the clean water and sanitation, and of course, partnership for the goal. So our strategic response to the educational challenges is to create equitable in access, that we don't need to leave anyone behind within the marginalized and fragile health system. We need to deliver our training for market readiness. So we welcome you, colleagues, because we want to work with you. We want to have computer learning centers, which we have face-to-face cultural building activities and a strong virtual offering which enhance the distance and gap, because we are a Pan-African university. And for us to be able to respond to the challenge, we need to develop fit for purpose leaders for Africa primary healthcare. And when we talk about the primary healthcare, it's because with time we have been able to focus more of the curative. We want to come back closer home. We want to come back to the basic of the primary healthcare. We want to stay just at the door of where we live. And fit for purpose is technically skilled, industry connected. We want to connect our students and our community to the industry. We want people with the entrepreneurs, understanding the primary healthcare context in Africa, appropriate soft skills that we are able to respond to our clients, to respond to the patients. We are able to work across the borders, culturally sensitive and competencies across our nations. We want to have that global perspective and connect globally. And as a leader, we also want to have a self-directed positive change. agent a culture of responsibility in their professions and also their area of expertise. So this is part of our strategic focus that I know that we have a tent next to us that I will be able to invite all of you to be able to go through. And to also just mention is that we have the nutrition and dietetics, and this is what we are looking to be able to partner and to welcome all of you to be part of our journey as we launch this new program. Having said that, we also have an Health Entrepreneurship Academy, which is able to provide the training programs and high up accelerator coaching and mentorship and commercial and enterprise zone, because we do acknowledge that there are challenges of jobs. We need to create the jobs and we need to have people to be entrepreneurs. So we are an African Heritage Center of Excellence that we provide the community outreach. We focus on Ubuntu, global exchange, and academia. And with that, I want also to mention that we have global cultural exchanges and we have the extension community of our students that they serve in various communities. What must happen now beyond? For our policymakers, we just want to ask that please allocate tight budgets to the nutrition. We need to have the nutrition within the USC benefit package, which is not there already, and establish mass spectral coordination so that we can be able to work together. We urge the health systems leaders to deploy nutrition professionals to all levels and integrate nutrition into the service delivery model. These are already there, but we need to strengthen its integration to ensure that at every level, this service is offered by the professional-led model that they work. Nutritional professionals, please own your expertise. Demand on your feet on the table. Generate evidences that you have published, share, advocate the data, and mentor the next generation, because we need them for us to move forward. Let's develop partnerships and we extend our arms as Amref International University that we will be able to work together. Let us fund the systems that we need to strengthen, not just program, but we need to support government-led and sustainable strategies and invest in the workforce development. To all of us today, let us commit to this knowledge, the health systems, and through them, let us nourish humanity. Asanteni sana. Thank you so much and be blessed.
Thank you so much, Dr. Kimaiyo. Thank you so much for such a captivating keynote, from strategic investments to strategic solutions, stressing on the integration to MCH among others, and stressing on the new paradigm that we must have towards integration. Of course, I really like very last end trying to give them more voice, so on and so forth. The conference director, I think the keynote has spoken on pillars very close to your heart. And from where you sit, I allow you to make a comment before we proceed with Q&A. I also encourage the membership in attendance to please put your comments, questions, etc. on the chat box so that we also use that to save time. Please, Conference Director.
Thank you, Chair. And Edna, that is very captivating. You know, Edna and I have been sitting in the same Cabinet Secretary's Task Force for Training. We were both appointed, and Yumbia and Oriama from Public Health. We used to say the trio is Edna, Oriama, and David on matters of health systems. Edna was a CEO, Nursing Council. She's now moved to Amref. And when she was appointed in the Presidential Task Force, the first day she called me and said, I want the data for all the nutritionists that have been trained, to include in the task force. And she could not give me space, even at night. She pushed us to the extent that I had to force my staff to produce that and give it to her so that it can be included in that report. And as you can hear, she has done well in dissecting nutrition service delivery. And her keynote goes directly to the cabinet secretary as a clip, because she has talked on my behalf. Now for today, I know you didn't expect this. Edna becomes now an associate member, the third one, in nutrition and dietetics free, under the category of ambassador of nutrition and dietetics in Kenya. We will do this when the time comes, the chair, during the licensing award. We now have 3. The first one was Professor Lokoruka. The second one was Professor Anali Grace from South Africa. Now Edna becomes the third. And by just, you can't say no from what you have heard. She has been pushing the agenda of nutrition. And we know that when she becomes the cabinet secretary, she will push the agenda for nutrition very soon. Thank you very much. Edna, you carry some dollars. I know where you are now. And please come and share with us. Thank you very much. And thank you for getting time at the wrong hour. Chair, I open it for you.
Thank you so much. That has been pronounced by the conference director, please. Congratulations, Daktari. And now let's open it up to a session of Q&A, comments, brief, and so on. Those online like me, please also put your comments on the chat so that we can pick and pass them over to Daktari for follow-up. But as we wait for that to come, those who are physically there, and Secretariat, please help me. If you have a question or a comment as a follow-up, excellent keynote, please.
Thank you, Chair. Let me, now that Professor Nguka is coming in as the new chair, let him make a comment. It would be indiscipline for the CEO not to allow the new chair to make a comment.
Professor Konyole, I think you are talking and we are not getting you. Oh, okay. Konyole, yes, we are hearing you. We are hearing you.
Please go ahead and
Okay. Thank you. Edna has talked our mind. And in fact, I was just talking to the CEO and I said, this is, when I will be presenting my keynote, is actually dovetailing with my keynote very seriously, because we have had interest of trying to make the world know the role that nutrition plays, and that it can never be taken as a supplementary service. It is actually the real service. And that if you want to solve health problems in Kenya and in the world, then nutrition becomes the key profession. Somebody was telling me that we are the future doctors. Then I told him, my friend, I think you're joking. We are the current and future doctors. And when I talk about that, we are not undermining other professions. We are saying nutrition has to play his key role that has not been played before. And I think Edna has just done that. And now my role is very easy when I will be doing presentation, because she has already talked almost everything that I wanted. I will just want to do that design. The design, now I'll be focusing on that design and how to integrate nutrition within the design and the health system blocks. So you can be sure I have a sneak preview of the presentation that we'll do. And I want to thank you, Dr. Keo, together with Edna. Edna, you are officially part of us going forward. And I've just been talking with Edgar here. So Edna, you have somebody who is very close to your name. Edna, Dr. Keo was continuously referring to Edgar as Edna, and you seem to be doing the same thing. So I've just told Edgar, Edgar is going to look for Edna after this, just to make sure that you synergize, because Edgar is doing a very good job also in advocating for nutrition. And that issue of HRH is one of our biggest problems. We have done calculations. And yesterday, I was trying to do calculations of what were the requirements per 100,000 population. We realized that in Kenya, we are so far, for every nutritionist in Kenya, as that we talk, is still serving close to 4,000 population, which is extremely low if you look at that ratio. And we said we required 60,000 nutritionists, and the population is continuing to increase. So advocating for more nutrition professionals, and you have said service for nutrition cannot be offered by just anybody. This is a training. You cannot purport to be offering a service. And we told our colleagues in the health profession, allow nutritionists to do their job. I was sharing with Virginia in her presentation, and we have had wars together with Dr. K, even in the floor of parliament. It makes me remember one of the key aspects when we were in Mombasa with the Senate committee. And we had a war with a fellow profession over why nutrition is important. You cannot undermine nutrition profession, even in the wards. When a nutritionist gives his or her advice, as a doctor, respect that. You cannot undermine. And I want to thank you, Edna. This is what we will continue to offer. We are going to stand with you in that war to make sure that nutritionists at the referral hospitals, and we have 4 of them in Kenya now, with the biggest being Kenyatta National Hospital. They are here. And we are going to be able to work together. And since we have the key pillars, Edgar, Edna, and the professionals, Dr. Keo leading the Kndi side, and we have our friend leading the union, please, we must do this. And we must do this before 2030. Edgar has given us a very strong indicator that we must eradicate within 5 years. God knows how we are going to do this, but we must eradicate malnutrition within 5 years. So thank you very much, Edna, for that presentation. We ask you to accept, Edna, just within that please do accept our new recognition for you. We want to give you just a little, of course, we will present this in our upcoming license. But before I hand it over to session chair, we are calling upon you. Go ahead and accept our new recognition. And you can say maybe a last statement. Thank you very much.
Yeah, and to relate to you, nutrition is part of me. My first experience in my referral, when I worked in pediatrics, I worked with nutritionists, and same in maternity. So I've worked in this journey. And my journey as an executive director, I work very closely with Dr. Kiwa and the administration. So you are all in my heart, and it's really my pleasure to really thank you so much for the recognitions.